I worked for 31 days last year and never got paid a penny. I'm not doing it for that. My practice dissolved when I left because we didn't get paychecks for 3 out of the last 8 quarters, so they all went to work for the hospital. I'm just tired of seeing those of us who stay up at 2:00 in the night taking care of your grandmother or taking care of your sick child continue to be cut and cut and cut. And there's only so much juice you can squeeze out of the lemon. I think we're literally at that point.
Hello and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you the most crucial conversation in healthcare and physician leadership today. As promised, with summer heating up and hurricane season right upon us, we are touching on some hot topics this month. Today will be no exception with our guest, the Honorable Dr. Greg Murphy. Dr. Murphy grew up in Raleigh, North Carolina, and earned his undergraduate degree from Davidson College. He next earned his medical degree from the University of North Carolina at Chapel Hill, then trained in urology and renal transplantation at the University of Kentucky before settling back in Greenville, North Carolina. Upon returning to his home state of North Carolina, Dr. Murphy established a highly regarded urology practice for many years and also served as chief of staff at Vidant Medical Center, which is now part of ECU Health. In 2015, Dr. Murphy's career took off in another direction when he had the distinction of serving in the North Carolina General Assembly, representing the 9th District, which is Pitt County, until he was later elected to Congress during a special election in 2019 to represent North Carolina's 3rd Congressional District. Dr. Greg Murphy is therefore also Representative Murphy and still sees patients in clinic periodically and is the only active physician member of Congress to hold that distinction. Congressman, welcome to the show.
Thank you for having me.
Our pleasure. So I want our listeners to understand a little bit about who you are. In the Leadership Academy course that I teach, the first rule we have is to seek first to understand and then to be understood, which, as you likely know, is adopted from the prayer of St. Francis of Assisi. Right. When you were only 20 years old, you spent a summer in India working in a Catholic leprosy hospital, and later in life, as an established physician and surgeon, performed medical missionary work in Haiti. Please share with the listeners what those experiences were like for you and what impact they had on you as a person.
Well, thank you, Lee. You know, I started at age 20. I actually thought I might want to be a medical missionary and have that for my career. And at age 20, I went over there, never been out of the country, went over to India by myself. And it was quite an experience, quite a very challenging experience. I grew up a lot in those 3 months. But it ignited a spark in me, really, to try to serve those less fortunate. I've traveled all throughout, especially East Africa. I worked in Swaziland, Kenya, some of the other countries in East Africa. I've worked in Nicaragua and, as you pointed out, worked in Haiti. Probably been overseas anywhere between 30 and 35 times working in impoverished areas of the world. That said, I've also worked in Eastern North Carolina for over 30 years, and a lot of poor individuals there also. Our payer mix is very, very challenging to keep a private practice alive because of so many indigents, so many Medicaid, no insurance individuals. So, you know, there are the Hollywood types of physicians who only see private insurance or no cash. But I think the vast majority of physicians are there to take care of whoever comes in the door. And that's our job, regardless of what they look like, regardless of what they believe. Our job is always the patient in front of us, regardless of their ability to pay or anything. And so I think that's a lesson that I learned long ago and still believe very firmly to this day.
I share the same belief as you. I never turned anybody away. It was an honor to take care of the person, and the rest had to be sorted out in some other manner. Well, you've had a long and distinguished career as a physician, held in high regard by your clinical peers. I've seen comments about you from people who have worked side by side with you. What elements of your devotion to the House of Medicine prompted you to serve in the House of Representatives?
Well, I didn't do this on purpose, Lee. I didn't raise my hand to get into politics. I was minding my own business. I'd finished my 3-year sentence, as I call it, as chief of staff at our very, very busy medical center, close to 1,000 beds, level 1 trauma center. And our North Carolina House member resigned in the middle of his term, and a lot of folks asked me if I would jump in, and I really had no regard to do that. Our state medical society really put the pressure on because there was not a single physician in the entire General Assembly in North Carolina. In fact, the person in charge of health policy for the House was a bail bondsman who hated doctors and hospitals. And so you pointed out, I'm a Catholic, good old Catholic guilt popped in. And so I threw my name in there and ended up serving. And, I think God had a good purpose there because I wrote and rewrote close to 26 times our anti-opioid epidemic legislation, which was passed unanimously both the House and the Senate in North Carolina, and the governor signed it. So I think there was a rationale, there was a reason that door was opened, and how I ended up in Congress was really a continuation of doors opening up. And I'm honored to serve today.
Yes, I understand the comment, your sentence as chief of staff, as a chief medical officer myself. I do understand that, but it's the opportunity of understanding how medical care is delivered that puts you in that position to write that policy and to enact that legislation, whether it's opioids or any other significant impact on a community that makes a huge difference. So clearly, serving as chief of staff gave you some level of advantage, whereas nobody else was in the medical field in the legislative body.
Yeah.
So are there any other lessons you learned as chief of staff that translated either in the state of North Carolina or now that you're up at the Capitol, that these new skills or that borrowed from your old physician skills to navigate government?
Well, I think it's important because, I've worked at the bedside, still work at the bedside, still operate. I operated this past weekend, ran a practice, and then was chief of staff of a big place. So you're in the boardroom, you're seeing how a medical system is run. You see all the different challenges with payers and, labor shortages, this, that, and the other stuff. And then I went to be senior chair of health policy in the state, and then on here to Congress. And so it's just helped me longitudinally to not have a narrow view that only, A plus B equals C, but to look at the big picture. How do these interlocking parts work? How do they make the machine come together? How do we actually effectuate the care, which is always for the patient in front of you? How do we fight those that are trying to, overregulate us, be it from the federal government, be it from insurance companies? So I think the depth and breadth of my experience really has equipped me well to deal with big picture issues. And here, we face in Congress the big picture issues, but we also have to have the on the grounds, the grassroots, the nuts and bolts that actually fix the issues. And that's where I have also worked also. So I think it's really the totality of experience and education that helps bring me forward.
Yeah, with all respect to all of the other members that you serve with, they don't go through training the way you and I went through training. Whether you think of it as an apprenticeship or a mentorship, you are trained. It is hammered into you how you think, how you decide, how you act, with the end in mind.
Yeah.
I've got to go this way to do that, to end up in this location with that patient in the OR. And if I don't know all of those sequential steps, I'm going to make mistakes and somebody's going to get hurt.
Sure.
And look, there are some seasoned leaders in the House and in the Senate who've had other careers in the military, law enforcement, what have you. But the training of a physician is a unique thing that gives you a whole bunch of skill sets, right?
Yep.
Yeah.
2 years of general surgery and transplant. That was enough experience in 2 years to really last about 20. So made me a better doctor, made me a better person. So
I hear you. So you are, and I quote you, fighting your ass off for physicians. You have co-sponsored and subsequently received a large degree of support for H.R. 879, also known as the Bipartisan Medicare Patient Access and Practice Stabilization Act, a bill that will prevent further cuts in the Medicare fee payments this year for physicians, and to provide some inflationary adjustment against the 2-decade downward, the slide of over 30% net of inflation in overall reimbursement to the private practice physicians. I just saw that a senator out of Kansas is sponsoring a similar proposition.
Yeah, Roger Marshall.
Yeah. And so what else can you share about the bill on the House side and whatever you know on the Senate? Like, what's the current status of this?
Yeah. And Lee, I'm not doing this with any bravado or any asking for a pat on the back, but I have been resolute and saying enough is enough. I'm tired of, I can't benefit from it because actually I have to work and I have to do it pro bono. That's what's required for house rules. I worked for 31 days last year and never got paid a penny. I'm not doing it for that. My practice dissolved when I left because we didn't get paychecks for 3 out of the last 8 quarters. So they all went to work for the hospital. I'm just tired of seeing those of us who stay up at 2 o'clock in the night taking care of your grandmother or taking care of your sick child continue to be cut and cut and cut. And there's only so much juice you can squeeze out of the lemon. I think we're literally at that point. And I've been told I was literally the thorn in everybody's butt to get what we did get through the House side. Now, these were difficult negotiations because while you would think, hey, it's great, everybody loves their doctors, why not do this? There's a lot of pushback. And sadly enough, Lee, physician payment has become a partisan issue. It's become a Republican issue. And I have Democrats in the Senate, Wyden, Bernie Sanders, that want to continue the cuts for doctors because they like pushing in consolidation. So I have been that pain in the ass, literally, to try to push things forward. We got a victory out of the House product. I would not say it's a win, but it's a one step forward, and we stopped the cut going downward. And what we're doing is we're actually doing it this way, and then we're going to start increasing it up with the MEI. Now, that's my victory. It's not my win. My win is to raise that up by getting rid of the 2025 cuts. I've had very thorough and very not difficult, but very discerned discussions with the speaker, and we're going to go after Medicare Advantage reform. Specifically, we have some really bad actors that upcode and do some really bad things. There's a lot of savings in there, and the speaker's promised me that we get some savings out of that. We can go back and erase the 2025 cut.
I really appreciate a couple of things that you said, and I need to expand on them for our listeners who may not understand how this works. By finding savings, whether it's waste or fraud, I'm not going to make that judgment. But if it's money that can offset what needs to get done, it's the right thing to do. Mm-hmm. And that way you're not borrowing for Peter to pay Paul and hurting a whole lot of people. You're taking it out of a bucket where it shouldn't be and put it in the right bucket. So that's great. You mentioned the partisan issue. When I looked on the .gov site, you have a tremendous amount of Democrats co-sponsoring. And I would submit that as the senator pushes, he too will get. I think the idea of supporting physicians is bipartisan.
Yes. However, Lee, I maybe should have clarified that it's really a couple of senior Democrats, and I'll point them out, Wyden and Bernie Sanders, who last time when I tried to do this, they blocked it because they were in the majority over in the Senate. This time, I think things will be a little bit more sympathetic to the plight of physicians. And no, you're right. We have a smaller doc caucus that they just formed this year with Democrats, and all of them were on board. But over on the Senate side, it's been a different thing, and it is a challenge.
Yeah, I get what you're saying, and I think our listeners will too. So let's pivot a little bit. You're working with the AMA and other organizations and other legislators to support independent physicians. But I mean, what is that really like to work in Congress to make that effective change? Are there any more parallels from the world of medicine in terms of the influence and getting that buy-in and being able to get in front of the speaker and move these issues forward? Any other parallels?
Well, Lee, I'll just give you my own personal experience. I've been here this fall. I will have been here 6 years, and I know most of the people around here, and they know that while I'm, generally a friendly person, I'm really serious about medicine. And I'm on Ways and Means, which is considered the most powerful committee in Congress. I'm the only physician on there, both Republican and Democrat. And I will say this because I've been told this by my Democratic colleagues, that they know when I talk about medicine, I'm not doing it in any political manner. I'm doing it about true medicine. And I'm talking from a position not in politics, but of regarding healthcare. And it's incumbent upon us, and this is one of the reasons I still practice. I do it because I love it. I do it because my patients appreciate it, but it also gives me a reference that literally I was in the hospital yesterday, or literally I was in the clinic last week, and I talked to a patient about this, that it gives me standing to make some of the arguments to my other colleagues about this. Now, remember, we have people, just as you pointed out, from people, a lot of different backgrounds. military, business, et cetera, farmers. I don't know. I mean, I wasn't raised on a farm. I don't know anything about farming. It's big for my district. And so I go to people who are educated and experts in that field, my other colleagues. And so those colleagues come to me when medical issues arise, and they know, both Democrat and Republican, that I'll give them a straight medical answer. And so, I think it's with time, and it's with people trusting my opinion about medicine, that I'm not being political about this, that they trust me to give them good advice.
And that's a skill we learn as a third year and as a fourth year and as an intern. You have to be direct, you have to be honest, you have to give the patient the right information for the
Yep.
decisions to get made. And again, not everybody is adept at being a truth teller and telling people what they need to know, right?
Yeah.
Yeah. So
Yeah.
historically, I'll look at myself, not you, physicians tend to be uninvolved in government and politics in particular. What are your thoughts about physician involvement in making change, whether it be political or otherwise?
Yeah. I'm gonna probably say some things that might get a few people upset, but I can't be concerned about that. I'm here to tell the truth. I ran a busy practice. I was at the hospital at 6:30 in the morning, either operating all day or seeing patients all day. Get home at 7:30 at night. Sometimes just eat dinner and then go do charts, et cetera, et cetera. So I was always politically active, meaning that I voted, but never politically involved. In fact, the first political sign I ever put in my yard was mine. And so it was a very steep learning curve, because you and I come from a field where people are working together. We work with patients, other doctors, against a disease. But politics is inherently adversarial. I have my view, you have your view, and I'm going to win. And that's an entirely different calculus, a different way of thinking. So it's taken an evolution. And I look and see all the different advocacy groups and all the different groups. Like today, I was talking with some realtors that came up from the district, or talking with some home builders, or talking with some farmers, or talking with different groups that come up. We don't, as physicians, understand what advocacy means. We really don't, because I think there's a belief that, hey, we're doctors, we take care of people, people will take care of us. Sorry, reality, that's not the case. Because there are people here that and I'll be frank about this. There was a member of former speaker staff that said a couple of years ago, "Oh, doctors earn too much; they don't need that anyway." And so it is not true. And our advocacy needs to be for our patients. This is one of the problems I have now with some of the leadership in medicine, is it's become advocacy for things that don't involve medicine. Doctors do not need to take their own personal politics into the patient room. They don't need to do it in their course of care. They don't need to be taught it in medical schools. They don't need to be taught it in residency programs. Our job is to advocate for patients. And in doing so, I think it's incumbent that we learn the political process. I'm going to say go to fundraisers, and I don't mean $5, $10, if I can say that here. You have to understand the nature of this beast, and how lawyers and how businessmen and other folks access politics. And so it's critical, because the old adage, if you're not at the table, you're part of the meal, is so very, very true. Now, again, it's not activism, it is advocacy. There's a difference. And you be advocate for your patient. If you want to have your own political activism outside of being a physician, fine, do it somewhere elsewhere. But when you're wearing your doctor's coat, or you're wearing that mantle, you're advocating for patients. And it is critical that we all do that.
So one of the problems that I see, and why I'm in physician leadership education, is we aren't providing physician leadership education. You go to medical school with a whole set of mental models about what's happening, but we don't have the curriculum that sets us up for advocacy, leadership, thinking about the financialization issues that occur. And so you get through this training, you're a competent clinician, you want to go out and do the thing you're trained for, and the ecosystem has not been explained to you. And you find yourself in a smart spot. And to your point, you believe if you write an order in the hospital, increase IV fluid rates to 75 cc, somebody's going to do it for you.
Right.
If you yell loud enough to fix a problem, someone will fix it for you. And as you're saying, activism is not the same as advocacy.
Right.
Understanding what's in the best interest of the patient is not yelling at somebody over here. It is doing the work. It's getting down there, right?
Yeah, yeah.
Okay.
I mean, how do we pay for things? How I look at some of my colleagues. I think there's been a lot of research done on a lot of things, but we're not doing much research on how to save money and how to save costs so that we can actually have a system that's viable in the next decade or 20, 25 years. And so there's a lot to unpack, but it's advocacy for patients.
Yeah. So healthcare, as we know, it's full of a lot of challenges. If you could redesign things within the communities that you serve, are there certain structural designs that you would love to see implemented? Any come to mind at all?
Well, I think our insurance industry is bankrupt, and I have to say this with strong opinion. I hate to use this term, but I think it's morally bankrupt because they have put profits over patients, and I see this time and time and time again, especially with Medicare Advantage. There have been some news programs recently where people have been denied care, and yeah, they're emotional things, but really looking at the grander scale from a 100,000-foot view. We fight for get pre-authorization. We get denials. We get this. I've had it as a patient myself, get denials. And so we've created an industry that while it's there, it has an honor of actually helping with healthcare, is now in the industry, is now in the business of denying healthcare and just making profits. The insurance company industry, and it goes also with pharmacy benefit managers, which people don't know about too much, which is one real reason that price of drugs in this country are so high. That is an avenue that needs absolute scrutiny and true reform.
Gotcha. Gotcha. How do you feel about entrepreneurialism helping to shift and disrupt these types of structures that are, I think, causing financial toxicity, right? You and I worry about a lot of toxicity that happens to our patients. As an oncologist, I worried about a whole lot of toxicity, but financial toxicity began to build in my practice.
Sure.
So what do you think? Can entrepreneurs?
If you go back to the Stark laws, Pete Stark put a lot of things in medicine or put a lot of things in statute that I think really hindered entrepreneurship in medicine. Now, don't get me wrong. I think we have some real folks in medicine that really do things for profit rather than patients, which is sad. And I'm an equal opportunity offender. I'll call them out also. But what you've created really is a system where we're just trying to rely on E&M codes. And sorry, that just doesn't make it. It's okay to be entrepreneurial in medicine. In fact, now that you have, sadly enough, where these people are cash only for the concierge practices, great. That's being entrepreneurial. That's getting out of under the thumb of Medicare, government regulation, and insurance companies regulation. Is that really the best way to deliver healthcare? I don't think so. I think it's okay to be one off. But systems of care are good, but systems also inherently are bureaucratic. And you end up with levels upon levels upon levels of bureaucracy. The consolidation that we've seen really since the ACA in 2014, in my opinion, has made costs go up, drive private practice, which I believe is the most efficient place of care, out of business. Do we need that type of safety net? Some practices can't make it and they get absorbed by hospitals. Absolutely, but we shouldn't be at the point where you have to get absorbed, because I think the private world is a little bit more efficient and actually more patient-centered sometimes than consolidated care.
Correct me if I'm wrong, but it was with the passage of the ACA that restricted the ownership by physician. Yeah.
Of
And
hospital. Yeah,
and you look at most systems, and I agree with you, there are bad actors in our profession, and
sure,
that is
sure.
our job to peer review them and deal with them, and the government can be a support for that as well. But if you look at most health systems that were either owned or run by physicians at that time, local or community based, and certainly the large systems that have a strong physician representation, their outcomes are awful good. The
Yeah,
success is pretty good. And you just got to weed out the bad
and they're
apples.
cheaper.
Uh,
And they're
uh,
cheaper.
yeah, and they're effective. So, look, I have one last question. It's multiple choice. You can change the answers as you see fit. But when things get tough for you, and I know they do, and I don't mean in the clinic or in the OR, what is your true north? What is it? The Hippocratic oath, the oath you took of public service, your faith, all of the above, none of the above. What do you do?
It is hands down my faith. I truly believe that our life on earth is a very short existence. I truly believe in God. I believe that Jesus is the incarnate of God personally. I have faith in my fellow man, but I know that we're broken. And I do believe in salvation. I do believe that in all. Well, there are some dark days. I've had some personal dark days, like many of our listeners will. 2008, my mother was dying. I ended up giving her last dose of morphine. My middle son, one of my children, developed refractory epilepsy for a while, and my practice fell apart. I went from being the second youngest of 5 doctors in 14 months to being the only one in literally the busiest urology practice in the state of North Carolina, not by design, but by necessity. Those were very, very dark times. So, we also have to step back and try to take a deep breath and realize that things will be okay. But at the bottom of the day, at the end of the day, and I still see this. I mean, just 2 days ago, I was in the office. When we walk into a patient's room, they are in a state of fear oftentimes. If they have a cancer, you know this, if a cancer diagnosis, and they are looking at us to be strong, to be direct, to be helpful, to be a leader. And sometimes we have to push our own feelings aside and do some of these things and play the role of leader. That doesn't mean we're always strong. It means sometimes we are weak. My Hippocratic oath is very important to me, but it's the oath I took to be a good follower of Christ that really is my guiding light.
Well, thank you for opening up and sharing that with us in our leadership class. We push values very hard. Your own true north is what will get you through. And they are sometimes extremely dark times. And
Yeah.
those are the lights that light our way.
Yeah.
Well, this has been remarkable. Thank you very much for being here. Anything else you want to share to the listeners before I give a wrap up?
It's about servant leadership. Where do you lead from? Do you lead from behind with a whip, or do you lead from in front by helping pull people along? And I think it's the latter is really what we ought to aspire to do. People follow strong leaders. They don't do that from being whipped to death or anything because there's no buy-in. If you see somebody is outworking you and asking you to come along, you're going to follow them. And that's what we're called to do as physicians. All physicians are by definition leaders, but we have to lead from in front. We have to lead by example. And we have to always, always understand whatever we do, we have to care about the patient first. And that's what's critical.
Agreed, sir. Well, you have been listening to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. If you are a CMO or looking to become one yourself, check out our new website, thefirechiefcmo.com, the only website dedicated to the Chief Medical Officer. Please leave your comments about the show. Tell us what physician leaders should be talking about and what they should be doing in healthcare today. As you can tell, I love this with a passion. I love talking with physician leaders from all over the United States. Reach out to me, give me your feedback, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.